two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 95, and I have been joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. We meet again after a break. That's good to meet after such a long time.
Absolutely. I think it was a well-needed break, I guess. So today, the topic that we have chosen is really a kind of controversy in critical care. And we have obviously come far away after Rivers has published his first landmark trial back in 2001 around resuscitation targets in patients with septic shock. There have been 4 iterations of surviving sepsis guidelines subsequent to that, and it still remains controversial around which target should we go with when we are resuscitating patients with septic shock. Now, there have been different parameters recommended in different guidelines. Having said that, the hard evidence around each of those parameters, it's still quite not there. So today we are going to dive deeper into each of these parameters and what's the evidence available around these targets in patients with septic shock. The most commonly used target is lactate. Anything lactate more than 2, we consider that patient is in septic shock. We start resuscitating them with the aim to normalize the lactate. So Dr. Checo, what is the evidence around this lactate-based resuscitation in patients with septic shock?
Yes, indeed, Swapnil, it's a very important question as to whether we should target lactate and what are the endpoints when we are in fact targeting lactate. It's pertinent to consider, why do the lactate levels rise in sepsis? Is it all because of hypoxia and anaerobic metabolism, or is it due to something else? If you look at patients with sepsis, at least in most patients with sepsis, at least during the early phase, there is no reduction in cardiac output. In fact, the cardiac output may be well maintained or even higher than normal. So there should be no reason as to why oxygen delivery should suffer. And there should be no reason really as to why anaerobic metabolism should take over. So that may not be the main reason, or may be the reason behind lactate levels rising in sepsis. There are several alternate reasons for lactate levels rising in sepsis. One of those is the increase in catecholamine levels. Because of the huge rise in catecholamine levels, there is an increase in aerobic metabolism of glucose. So glucose gets metabolized aerobically in a much, much upgraded fashion compared to normal. And that results in an increased formation of pyruvate. Normally, as we know, the pyruvate gets converted by pyruvate dehydrogenase, and it gets converted to acetyl-CoA, which enters the citric acid cycle to yield 36 molecules of ATP. However, in sepsis, the pyruvate load is so high because of the excessive catecholamine release and excessive aerobic metabolism of glucose that the pyruvate dehydrogenase gets overwhelmed by the excess of pyruvate. Not only that, there is some evidence to suggest that the pyruvate dehydrogenase may not function optimally in patients with sepsis. So that results in an accumulation of pyruvate, less conversion of pyruvate to acetyl-CoA. So what happens at this stage? The pyruvate takes an alternate pathway through lactate dehydrogenase and gets converted to lactate. And this is the main reason why lactate levels rise. Is this lactate really bad? Not really, because the lactate is taken to the liver first for gluconeogenesis. Although this pathway doesn't yield very much in terms of ATP, it is still an alternate pathway. And second, the lactate so formed is shuttled through to other important organs such as the brain and the heart, which are able to utilize them by conversion to pyruvate. So they are able to utilize them. So the lactate generated is in fact a defense mechanism to overcome the situation of excessive pyruvate production in sepsis. There are, of course, other reasons as to why lactate levels should rise in sepsis, including liver dysfunction, which we see in many patients with sepsis, septic shock. And if the liver is dysfunctional, it results in a reduced metabolism of lactate and the lactate levels rise. The lung, if there is ARDS, may be a source of lactate production, and that may increase lactate levels as well. And of course, occasionally you do get patients in severe sepsis and septic shock who have a problem with oxygen delivery, who have a problem with mitochondrial function. There is mitochondrial failure, and they resort to anaerobic metabolism, and that, of course, will result in raised lactate levels. But this, of course, is a relatively less likely possibility compared to the other pathways that result in lactate rise.
Thanks, Dr. Chakkar. So as you rightly said, lactate resuscitation always lags behind the clinical improvement and results in over-resuscitation. And I think that's something that we have to keep in mind, that we don't need to just chase a number, but also look at the patient holistically. Now, the second important parameter that has been recommended to follow during the resuscitation is around capillary refill time, which is not a kind of new parameter. It has been proposed many decades ago and has been a part of very medical school level teaching, that we look at capillary refill time, press for 5 seconds centrally. And then if the capillary refill time is more than 2 seconds, then that indicates that patient is in shock. However, performing capillary refill time, it's not very accurate, it's subjective, and it has got its own limitations. So what is the evidence around using capillary refill time as a part of your resuscitation strategy?
Yeah, when you talk about capillary refill time, one needs to understand that there may be a lack of coherence between the macro and microcirculatory parameters among patients with sepsis. And what we should really aim for is what happens at the microcirculatory level, although measurement at that level is really elusive even at this stage. So one of the options, clinical options, is to assess the capillary refill time to assess the microcirculation. And normally, many of us do that by just applying pressure on the fingertips or the toe tips of patients and see whether they refill within a period of 3 seconds or not. And today, we have a randomized controlled trial also that looked at capillary refill time in the Andromeda shock trial. So they compared a lactate guided strategy with a capillary refill time guided strategy. And the way they check capillary refill time is by using a glass slide. They press the glass slide against the fingertip until the finger blanched, and then took the pressure off and looked at how much time it takes for the capillary refill to happen. Anything more than 3 seconds was considered to be prolonged. So they did this study comparing normalization of lactate versus capillary refill time of 3 seconds or less. The primary outcome was the 28-day mortality. In fact, they found that the 28-day mortality was lower, but not significantly so, with a capillary refill time guided strategy compared to a lactate level. But of much more importance is another finding. Among the patients who are randomized to the lactate guided therapy, there were several patients who attained resuscitation endpoint as in capillary refill time of less than 3 seconds, well before their lactate levels normalized. However, being in the lactate arm, they continue to receive resuscitative interventions with the aim to normalize lactate. And among these patients, surprisingly, they found that the mortality was higher. In other words, if you try to resuscitate further after the capillary refill time has normalized, you might end up causing more mortality. And they also found that in these patients in whom the capillary refill time had normalized, but they went on to give more resuscitative interventions, the use of intravenous fluids was much higher. 1 liter compared to 500 mils was the median fluid administered. So the Andromeda shock trial really demonstrates that the capillary refill time is a very important clinical parameter that reflects the microcirculation, which is easily performed by the bedside. And of course, it's important to remember that even the surviving sepsis guidelines in their recent iteration, they do not recommend normalization of lactate levels. They just recommend decreasing lactate levels rather than normal lactate levels. So very important not to chase down normal lactate levels with excessive resuscitative interventions, which might actually be counterproductive and lead to harm.
Yeah, that's right, Dr. Chakos. So I guess at least now we got some evidence around capillary refill time. And as I mentioned, central versus peripheral capillary refill time still remains issue because I think an Andromeda shock trial did actually look at the peripheral capillary refill time rather than the central capillary refill time. Now, moving on to the next target that is very commonly used in resuscitation of patients with septic shock is the MAP target. And I must say that's probably the one of the most well-studied target amongst all other targets and has been widely adopted as a strategy to target MAP of more than 65 millimeters of mercury when we are resuscitating patients with septic shock. So what's the evidence behind this magic number of MAP of more than 65 millimeters of mercury?
Yes, Swapnil, as you rightly point out, the mean arterial pressure is one of those targets that everybody follows by the bedside. It's easy, simple to follow. The nurses can titrate vasopressors to target a pre-specified MAP level. But the evidence around it, we have had a couple of studies in recent times as to what may be an optimal MAP to target. And the surviving sepsis guidelines, of course, always suggested a MAP level of more than 65 millimeters of mercury. A couple of studies, the sepsis SPAM trial, which was in patients with septic shock, targeted a slightly higher MAP level of 80 to 85 versus the conventional 65 to 70 millimeters of mercury. And this was a randomized controlled trial. And they looked at the 28 and 90-day mortality between patients who had a target MAP of 80 to 85 versus 65 to 70, and they found no difference in the mortality at either 28 days or 90 days. However, they came up with some subtle findings on subgroup analysis, including doubling of creatinine levels among patients who had a significant increase in the doubling rate of serum creatinine levels in patients who were targeted to a lower MAP compared to those who had a higher MAP. So this suggested that renal dysfunction may be more among patients if you target a lower mean arterial pressure. The requirement for renal replacement therapy was also higher among patients who had a lower MAP target of 65 to 70 compared to 80 to 85. This, of course, was only based on subgroup analysis. The study was not actually powered to look at this. So you can't come to any kind of firm conclusions based on these results. And these findings seem to be particularly relevant in terms of renal function in hypertensive patients. So this study, if anything, suggested that in patients with hypertension, it may be advisable to aim for a slightly higher mean arterial pressure. However, the more recent 65 trial came up with contradictory findings. This study included patients who were 65 years or older, and they compared a lower MAP of 60 to 65 millimeters of mercury versus usual care. So this was a strategy of permissive hypotension, if you may call that, of a mean arterial pressure of 60 to 65 millimeters of mercury compared to usual targets based on physician judgment. They looked at the 90-day mortality, but there was no significant difference in the 90-day mortality between patients who had a mean arterial pressure of 60 to 65, which is slightly lower than recommended compared to usual care. They also came up with a finding, in contrast to the sepsis SPAM study, they came up with the finding that in patients with chronic hypertension, survival may be better if you target a lower MAP of 60 to 65 millimeters of mercury. So these studies are in fact contradictory, but I think the overwhelming evidence seems to suggest that regardless of age, regardless of baseline blood pressures, a mean arterial pressure of 60 to 65 may be just right in most patients.
Thanks, Dr. Jacko. So I guess the controversy around MAP still exists. So I guess moving forward, there are some proponents of echocardiography who recommend using bedside echo rather than sticking with a crude parameters such as mean arterial pressure, because there can be discrepancy in MAP depending upon what technique you use to measure mean arterial pressure. And echocardiography seems to have more accurate estimation of actual stroke volume using the VTI through the aortic flow. So, Dr. Chakko, what's the evidence of using echocardiography or stroke volume estimation using echocardiography in resuscitating patients with septic shock?
Ultrasonography is an important tool to assess shock by the bedside and decide on whether your patient needs more fluid or does he require a tiny dose of inotropes to get the heart kicking. There are three things that you aim for mainly. First is the diameter of the inferior vena cava and the variation in the diameter with respiration, which may not be very much applicable in patients who are breathing spontaneously. The second parameter to look at is the presence of interstitial lung fluid in the form of B lines, which is again very easy to visualize by the bedside. Third and most important is the measurement of cardiac output. You don't need really to measure the cardiac output because measurement of the stroke volume using the velocity time integral may be good enough in most patients. And the way you do it is by getting a apical 5-chamber view. You need to get a view of all the 4 chambers and the left ventricular outflow tract and the aortic valve on the apical 5-chamber view. And you place the pulse wave Doppler cursor at the left ventricular outflow tract. And when you interrogate with pulse wave Doppler, you get the typical waveform that represents the velocity time integral. So you need to chart out this waveform. And then once you measure the aortic diameter using the simple calculation pi r square, you can actually measure the cross-sectional area of the left ventricular outflow tract. And this multiplied by the velocity time integral will give you the stroke volume. And the method by which you assess volume responsiveness as a dynamic parameter is by measurement of the velocity time integral when the patient is in the supine position. Then you repeat the measurement by after passive leg raise. So you have 2 measurements, pre-passive leg raise and post-passive leg raise. So if the velocity time integral shows a difference of more than 12% between the pre and post-passive leg raise measurement, it suggests that your patient may be volume responsive. So that's a very useful method by the bedside, usually easy to perform in most patients. Of course, you may have difficulty in some patients to get a 5-chamber view, but in many of these patients, you should be able to get a good 5-chamber view and assess the stroke volume. As I mentioned, you can measure just the velocity time integral alone because the aortic diameter doesn't vary very much from beat to beat or from inspiration to expiration. So an increase in the velocity time integral after passive leg raise suggests volume responsiveness and your patient may require more volume.
Thanks, Dr. Check. The use of echocardiography and ultrasonography in intensive care has obviously increased over the period of time. And now it has almost become an integral tool to our assessment of patients with septic shock. Now, you mentioned before about the assessment of macrocirculation and microcirculation. And I guess microcirculation seems to be more important than microcirculation. So what are the ways to assess microcirculation? And I guess one of the commonly used way to assess microcirculation is using the CO2 gap, using the sublingual or capillary CO2 levels. So can you tell us more about it and what's the evidence behind the use of microcirculation as a resuscitation target?
Yes, one of the easy bedside tools to assess the microcirculation is to look at the carbon dioxide gap, which is the difference between the central venous PCO2 and the arterial PCO2. Normally, the central venous PCO2 should not be more than 6 millimeters of mercury compared to the arterial PCO2. So what happens is if the circulation slows down and if there is stagnation of circulation, it doesn't wash out carbon dioxide from the tissues and the carbon dioxide levels start rising in the venous blood. So because of this, you get a wider gradient between the central venous to arterial PCO2, which is more than 6 millimeters of mercury, in patients with circulatory shock and low cardiac output. So this is another important parameter that suggests reduced microcirculatory flow. So as I mentioned, there are many clinicians who do this, practice by the bedside, look at the PCO2 gap, and if the gap is more than 6 millimeters of mercury, you aim to resuscitate more, which may be in the form of more fluid or the use of inotropes to to increased contractility. There aren't many studies that have addressed this particular parameter. There are a few observational studies which suggest that it might be useful. So it is one of those parameters that may be used more in the future, being less invasive, easy to measure by the bedside, and easy to repeat measurements and titrate your resuscitation efforts as well.
Thanks, Dr. Checker. So I guess it is still in probably early stages before we start widespread use of capillary microcirculation as a part of the assessment. Although it's, as you said, it's quite easy, can be performed at the bedside. We are still not at that stage where we are using it for every single patient who is coming through the door of ICU. So what's your approach in your ICU when you resuscitate patient with septic shock?
What we would do and what I advise my trainees and junior colleagues to do would be not to consider a single parameter, not to target a single parameter like lactate as your resuscitation target. You look at the patient with a holistic point of view. Do not put all your eggs in one basket. First of all, you must ensure that your patient is adequately volume resuscitated in sepsis. This may not be with the arbitrary volume of, say, 20 or 30 mils per kilogram in all patients. You need to assess what is the target that you're aiming for, particularly the dynamic indices of hemodynamic parameters. Dynamic indices are very important. And one of the easy methods by which to assess whether your patient is volume responsive is to look at the VTI variation pre and post passive leg raise. And of course, you can also look at the IVC diameter variation in patients who are not breathing spontaneously and directly visualize the lung to look for interstitial fluid. Of course, if the lung is wet, you would certainly hesitate to give more fluid to your patients. And very important to also consider the microcirculation. And one of the easy things to do by the bedside is to check the capillary refill time. Although this is not very commonly performed, I do follow this practice in our patients. And I also train my juniors to look at the capillary refill time because this may be a very important parameter. And a refill time, if it's more than 3 seconds, which it again denotes that your patient may not be adequately resuscitated. Then, of course, mean arterial pressure. You need to choose the right target for your patient. And generally speaking, compared to what we used to target previously, we used to target 70 millimeters of mercury or more. These days, we accept slightly lower levels of mean arterial pressure, but this, of course, depends to some extent on the baseline blood pressure of the patient that you are treating as well. So a lot depends on considering all the parameters put together, not a single parameter alone. Lactate levels are also useful, particularly if they are coming down. It suggests that your patient is improving. You need not pursue further efforts at resuscitation to try to normalize lactate levels because this may take a very long time. In fact, it might take more than 12 to 24 hours. And if you keep on giving these patients more fluid, keep on with other resuscitative interventions, it might actually lead to harm. So the bottom line is to look at the holistic view and look at the patient from not one, but many different angles and follow a concerted strategy.
Yeah, I agree with you on that, and that we can't just use one parameter to guide our resuscitation practices, and we have to use different parameters to guide our resuscitation strategies. And I guess rather than chasing one particular number or absolute number, the trend in patient's clinical trajectory is most important parameter. And I think has been the trend worldwide now, that we have moved away from using single parameter as target for our resuscitation and then using the multiple parameters to guide our resuscitation strategy. Also, we have moved away from using too much of fluid to normalize lactate, and we started using early vasopressors to achieve that map of more than 65. And in meantime, use your other adjuncts such as echocardiography or ultrasonography to determine what's the underlying cause of the shock. So that sums up today's topic. We'll be back with another controversy in weeks' time. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening. We'll meet again next time. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.